In which case, it's my pleasure to introduce our next session on the effect of COVID on your patients with colorectal cancer. And here to talk to us about that is Dr. Konstantinos Kamposioras, who's a consultant in medical oncology at the Christie. And I'm really delighted to have you here today and can't wait for this session. So thank you for that. I'm going to let you take it away.
Thank you very much. It's really a pleasure me participating in this excellent prepared webinar, and I really enjoyed the two previous sessions, really very educational. So the title is quite a challenge because we are still trying to identify what is the effect of COVID on colorectal cancer patients. So I will share with you some literature which is giving the overall picture, but then for the first time you will we'll go through the results of two surveys that has been conducted by Christie and Bowel Cancer UK, which I find it really fascinating on how we can proceed the management of our patients. So if we move to the next slide, this slide shows how things have evolved over the last 9 months. So since January 2020, when the first cluster of COVID was identified in China, things were obviously developing very fast, and in March, WHO declared the pandemic. As we stand, and actually, as you can see, this is the figures from 11 September. So a few days ago, it was 28 million of new diagnosed cases. Today, just checking before I joined in, it's 29,800,000 cases. And we're heading to more than 10 million deaths globally. So it's a huge impact that this pandemic will have in all different levels of care, including obviously cancer care. In the next slide, we can see factors that might affect how the cancer patients can be affected, leading to excess mortality. So we know that there are delays in the diagnostic pathways, changes in bowel screening in our case, changes in how the chemotherapy has been delivered, setting different priorities and the category groups. But also, it's not only that, it's also the overall management of patients through management of other non-communicable diseases, health consequences, which I'm afraid this will follow. We haven't still witnessed what is coming with that. And obviously, all of us have witnessed patients who unfortunately died due to the COVID infection. So in the next slide, Amy, please. The initial reports back in April suggest that there was a reduction in 60% of the chemotherapy attendances. So this data come from a study all throughout the UK, from London, Northern Ireland, Leeds University, and this has really reflected the changes in how we have received, how the chemotherapy units have responded. But more important, and this is something that will follow in the next coming months, is the drop in referrals for diagnostic management in the diagnostic pathway by almost 76%. So it's a huge drop in referrals. Obviously, we'll face that, and that's why I said from the very beginning, it's difficult to predict how things will be affecting our patients. Still, we really know different parameters. In the next slide, Amy, this is, and I'm not sure if this is very well visible. So delays in the 2 ways pathway or 2 weeks pathway, but even any kind of delay can have a huge impact on increasing mortality attributable to these kind of delays. So a 6-month delay can increase cancer deaths by 9,000. That would not be expected to happen. In case of colorectal cancer, this is around 2,000. So it's a huge number considering what effort has been implemented to address the management of all different types of cancer, including obviously colorectal. Next, please. And this table shows that a reduction by 3-month delay can increase the 10 years, reduce the 10-year survival even up to 16% in colorectal cancer. So again, it's really impressive numbers. Next one, please. So this is how things, just to give you a picture how things have changed in the last few months. But to get the real implication of these changes to our patients is only by asking them. So we have set up 2 surveys. One was conducting the colorectal from the colorectal group at Christie's, involving 140 patients, and the second one was through Bowel Cancer UK with 720 patients. The first one in June and the second one in July. There are some changes in the specific characteristics, but altogether there are quite comparable data, which I will go through that in a bit. So in the next slide, please, we can see that most of the patients, and this stands for both surveys, they didn't have active disease, or the disease was under control, and the majority of patients carried on with the chemotherapy, with only 1/4 having delays of treatment. So this is the main characteristics of the population. But in the next slide, we start to see what has been the changes. So first of all, as you have all experienced, we started a lot of telemedicine, so a lot of phone consultation or video consultation. In the Christie's, we almost up to 80%, especially during the peak period, went to telephone consultation. We hadn't started the video consultation as yet, so the numbers are quite low. But what is good to know is that the phone consultation met the expectation of our patients. And in the next slide, you can see that this is similar to what Bowel Cancer UK has shown. So 75 or up to 75% of the patients felt that the telephone consultation met their needs, which is quite positive. We need to consider that in the future. And then we asked what would be the preferred mode of consultation. And here we can see that face-to-face has been one of the main options, but patients want to be engaging more. So they need to have the option to choose. And we know how many times patients have to travel from distant areas to visit the treating hospital. And the similar results have been picked up in the Bowel Cancer UK survey, as you can see here. So it's something that in the implementation of future service delivery should be taken into account. The next area that has been investigated is how the change in the radiology appointments, and also discussing the radiology results over the phone has been received. So at Christie's, there were up to 40% of the cases of the patients who had some kind of discussion over the phone about the results, and it was really well received. And this is quite similar with the second survey as well. Again, when we asked the patient how they would like to be contacted about the scan results, there is a significant population who would prefer to have it over either face-to-face, but most of them would like to be discussing the options or given the option to choose on their own. So we need to identify that group of patients who don't need to come just for a CT scan that can be otherwise discussed over the phone. So that's something that as service delivery it could be considered for the future. In the next slide, it was about how well and safe patients felt about visiting the treating hospital. And again, I think most of our patients trust on the cancer teams, and in the Christie result is up to 94 that they felt safe to come. I found it much more interesting, the results from the Bowel Cancer UK, in the sense that there was a variation from 50 to 90%. 90% was for those people, for those patients who have not yet started the treatment, meaning that they wanted to they were keen in here to go to meet their cancer team and start the treatment. But those who have been on the treatment or experiencing the COVID as part of the healthcare system, so they have been more worried about that. Another factor on the table on the right that we should focus is the changes that has brought the COVID pandemic with the family. So most of our patients did not have the chance to have somebody with them, and obviously this is to protect everybody. But we didn't give them the option to choose, or didn't give the option to have an alternative way to communicate with the family, which, as you know, quite a few of our patients are quite vulnerable, so they need support. So we need to identify the best way to engage the family members when this is requested. Next one, please. So this is the same for the Bowel Cancer UK. Now, going more specifically about the concern that COVID, in fact, pandemic has brought, we are assessing the communication that patients were receiving, and it's positive to see that the communication has been there. It's not always that great, but definitely an area that could be improved. So more than 70% felt that there was good communication. But also what is really useful here to notice is that despite the period of the pandemic, they weren't concerned about COVID that much, but they were still worried, and this would be expecting to a certain extent, about their cancer treatment. So we cannot ignore that although we live in unprecedented times with this pandemic, cancer care needs to carry on as normal as possible, and we need to take this into account. In the right panel, you see that the concern to get COVID infection was not too high. So in the participants from Christie's, it was around 20%, and the next slide shows that it was a bit higher from the Bowel Cancer UK study. Just to notice to remind that the Bowel Cancer UK has the 90% were coming from England, but there were also other parts of the UK involved in the study, on the obviously different cancer centers. In this slide, we see that the mental health has not been really affected by the COVID, and this comes in a sense a bit to opposite to what we have seen in other reports. So there is a report from the from US about ovarian cancer, and there was a lot of anxiety and concern about the COVID in that population, and there also a group of younger cancer patients who again were really worried about the psychological impact of COVID. This has not been confirmed in our patient group. So in the left panel, you see that the effect of mental health has been really minimal. And but in the case of the second survey, there is a bit different distribution. So maybe this could reflect that having been in a cancer center might be that they feel more protected, but also this is just a speculation. We will need to analyze the data further from this second survey. In the next slide, this is only the data from Christie's now, because we haven't managed to do the analysis yet about the anxiety. So one of the questions or one of the items was to assess the anxiety levels for cancer patients, and this was done by the GAT-7 scale, which is a standardized scale. So patients were asked to report how frequently they feel anxious or worried about things. And what has come out is that less than 20% felt anxious, and this is on the threshold of above 5. And for those who are not very familiar about this scale, the scale between 5 and 10 is that it characterizes a group of patients who have only mild anxiety, and above 10 is the severe anxiety, so the severe or moderate and severe anxiety. So in our group, it was only 6% that had moderate or severe anxiety. So the levels are quite lower from what somebody would expect. And again, this is really positive, and we need to consider again the cancer care as the main issue for our patients. And then we did different analysis, univariate and multivariate analysis, to identify either groups or factors related to anxiety. So we couldn't really specify a certain group, like somebody living alone or certain age groups or gender, as a factor for increased anxiety. But what this table shows is that those who have answered that they felt that the COVID pandemic had affected the mental health, or those who said that the mental health has affected the experience of cancer care, were 3 more times prone to report levels of anxiety. And those who were concerned that they might get COVID-19 had 2.3 times more risk, let's say, to have anxiety. So this is also a result that we found very interesting, in the sense that in the clinic, if we ask our patients, do you feel that you're affected from COVID, the COVID will affect your mental health, and they say yes, so this might be a group that we might need to investigate a bit further and do some more assessment to identify if this reflects to anxiety, and then obviously provide more support. If we manage to validate that with the second survey, I think that will make a strong case for discussion. And in the next slide, so the next few slides is about awareness of support services. So at Christie's, actually, I wasn't very pleased to see that only 50% of the patients were aware of support services, and they have used them really rarely. So I'm not sure if this is something to do that obviously they weren't really concerned. There wasn't any issue with that they needed support, as we have seen in the previous slides, or they weren't aware as yet about the support mechanism available. But in the next slide, you can see that I think this is more reflective of what I would expect to see, in the sense that there is a lot of awareness. It goes up to 90% of different supporting mechanisms and services. And the patients have been using charities or national organizations up to 30%, which is something that reflects more the expectation. But again, this is something obviously to work on and understand why, especially the Christie results have shown such a low awareness. The last two slides is quite interesting again, in the sense that our patients have fed back how well they felt supported by different sources. So friends and family really scored highly, and I believe this could be expected. The cancer team at Christie and the specialist nurses did really well, but this is not reflected when they fed back about GP or community services, and also by government. So we know there have been a lot of changes in the community, but maybe this reflects how they have perceived all these changes. Similarly, we don't know about what were the expectations of our patients during this period, because everything has changed so abruptly that nobody was prepared, more or less, to reflect and provide the appropriate support. But definitely this is something we need to feed back. And the similar results were seen from the Bowel Cancer UK. Friends and family really supportive. There is variation on how the different cancer teams have supported their patients, and community services may have not done as well. Again, we need to explore that a bit better. So this is I would say the first flavor of these two surveys, which have come up just the last few weeks. We know that COVID has brought significant changes in the patient of cancer. In patients with cancer, colorectal cancer is included in that. In our survey, in these two surveys, we couldn't really see that there was a lot of anxiety or loss of distress to our patients, and this is really positive. We couldn't identify either certain groups that would need more support, but it was positive to see that the friends and family were really helpful to their relatives. But we need to reflect if we can do anything better to navigate them through their journey. The way the support mechanisms have been accessed is also of concern from our end, because we need to understand why they weren't aware to start with. And if these three questions I've shown you in the multivariate analysis are validated with the second survey, I think will be an easy way to identify patients in need. And with this one, I would like to really thank you for the excellent opportunity to participate in this forum.
Well, thank you so much. That was absolutely fascinating. Really, really interesting to see. And we've had a couple of questions in the question box, which I wonder if we could just have time to have a look at. So there's one question said, would the changes in patients having a relative in consultations be because hospitals were closed to visitors?
Yeah, but similarly, I mean, when we started, everything was moving to phone consultation. when we started doing the video consultation, which was around beginning of June at Chris's at least, the difference and the feedback we were getting was much, much better. Obviously, this survey does not reflect that because there was so small number of cases. But one way is the video call. But we know that a lot of them, especially elderly patients, are not very IT literate, so it's difficult to expect everybody will be able to join. Alternatively, it's through through the loudspeaker over the phone.
Absolutely. There's another question as well. How have you managed to reinitiate routine surveillance CTs for oncology patients? Comment here, it's taken our trust some time to start routine scanning and have outsourced to private hospitals to reduce the backlog. I'm sure that's something that's familiar to lots of people.
So I didn't really get the question, sorry.
So how have you managed to reinstate routine surveillance scans for oncology?
So again, there was a period that were really, a lot of scans were deferred. And then it depends actually to radiology, right? So then we're trying to prioritize. So let's say a patient who just finished the adjuvant chemotherapy, it wasn't an issue to go back, to put the scan back 1 or 2 months. But if there was something that we needed to make a decision, I think the radiology department was understanding that, and they were quite helpful. I think we are now back to 80% of what we should be.
Yeah. We've got another comment here that says equally have problems getting surveillance CTs done, huge backlog. Impact of not being done on time is not yet known, and I think it's something that's going to unfold, isn't it?
Yep, and that's why I was saying that there are many things we don't know yet. This is my main concern is the front part of the pathway, the delays that are happening there. I mean, I'm doing also acute oncology in a peripheral hospital, and the number of MSCCs that we see has increased dramatically. So we're seeing 1 case per month. Now last month we have 5 or 6. So I'm not sure it's just a random one or will be knock-off effect, but definitely something to be noticed. And I think the neurosurgical team here in Manchester was witnessing that. So there are issues that will follow, and we're still learning. Yeah. And obviously, the other factor we try to investigate, I mean, to assess that is how the delays on chemotherapy have affected patients. We don't know that yet. So we try to, as a measure to reduce the footfall, those who have been stable for quite some time, we try to give them some time off. But again, we had patients who were progressing after a couple of months. So it's a judgment call. And during the pandemic, the initial peak of the pandemic, the concern was much higher. So now we learn to live with that a bit more and understand how the disease is affecting cancer patients. And the good, inverted comma, thing is that there are some reports suggesting that cancer patients are not in high risk during the COVID pandemic as the general population. But this is just a couple of reports that have come out.
Yeah. So a couple more comments about people struggling with endoscopy capacity as well, even symptomatic patients not being done, and huge backlogs. And a last question here, I think, before we move on, but do you, I guess this is for any of the panelists actually, do you see a more robust government response for maintaining cancer services in the next wave? And I don't know if any of our panelists would like to jump in on that.
I'm not aware, to be honest, but I think this has been flagged up as a major issue. So a lot of resources have to be implemented to absorb this backlog. This will have the next wave of implications for the cancer patients, all these kind of delays in the diagnostic pathway.
Yeah, absolutely. You say, oh, sorry, Rob.
Could you just repeat the question? My internet cut out slightly.
Oh, it was, do we see a more robust role for government in dealing with any potential next wave of the pandemic?
So this is my personal perception. I think last time we became, as an organisation, as a country, we became COVID fixated. and all of our focus was on the fear of this unknown or relatively poorly understood virus. I think if there is a true second wave, I think a lot more weight will be given to the costs of focusing on COVID, and specifically for this group, the cost for cancer patients and missed surveillance, missed treatment, missed surgeries, delayed surgeries.
Yeah, absolutely. I think the impact is, again, not yet known, but we can see the scale of the backlog. It's huge. I'm going to leave it there and move us on. I'm conscious of the time, but thank you so much again, Konstantinos. That was absolutely fascinating stuff. And I just reiterate what Claire said at the top of this meeting, that all the slides will be available to everybody at the end of the session, and we are recording the session, so you have an opportunity to look back if there's anything you'd like to revisit.